I'm Dr. David Rubin from the University of Chicago Medicine. This is Best of the Day from the Advances in IBD meeting in 2014. We're here in Orlando, Florida for the first time, but this is the 13th annual meeting. Joining me and co-chair this meeting for the last 12 years is Dr. Stephen Hanauer, who is the medical director of the Digestive Health Center at Northwestern Medicine in Chicago. Dr. Hanauer is also the president of the American College of Gastroenterology. Welcome, Steve.
Thank you, David.
So this is a great meeting. Congratulations.
I'm actually surprised. I thought we had a great footprint in Hollywood, but I'm delighted to see an additional several hundred patients here. We're up to about 2,000.
Well,
not patients but
attendees,
participants.
Right?
Yeah.
Although some patients are here too. I met a whole group who are actually, they have press passes and they're social media blogging from the meeting.
That's fantastic.
So it's actually terrific. And maybe the footprint was a little bigger and it's just Florida,
yeah.
Right? But people seem to be enjoying the meeting, so congrats. Yeah. We're going to talk about some of the clinical things going on at this meeting. This morning was a great session on biologics and positioning them and some of the future thoughts. And maybe we can start with that, and then we'll talk about some of the other things happening here. So you gave a wonderful presentation on positioning biologics in Crohn's disease. Do you want to give the listeners at home some updates on that?
Well, first of all, Bruce Sands gave a terrific basic introduction to biologics focused on ulcerative colitis. So I didn't need to deal with the mechanisms of the anti-TNF or the anti-integrin therapies. And he discussed the positioning in ulcerative colitis, which is pretty much similar for the positioning in Crohn's, which has been for patients who were not responding to conventional agents. And Crohn's is a little bit different than ulcerative colitis because of the progressive transmural complications, the strictures and the fistula that occur over time. So I took the stance that although biologics were very effective, that we need to change the positioning.
So where should we position them? One of the questions from the audience, because I was moderating the session, as you know, was can we really talk about early Crohn's when so many patients come to us and they've already had a lot of progression to begin with? So tell us a little bit more about the subtlety in understanding that.
Well, that's a really good question about what is early Crohn's disease. We don't have a real definition of it. Personally, I look at early Crohn's disease as superficial. The Crohn's becomes later or progressive based on deep ulcers, which are the bad prognosis. There's maybe 20% of patients with Crohn's disease who have early lesions, the aphthous lesions, and never progress. And to me, it's the depth of the ulcers that really makes that transformation.
I think one of the other messages you made today, though, was about not letting it progress once you know they have it. So how do you monitor patients and know that you should get them on these therapies and that they're even doing what they need to do?
So we know the factors that are, not factors, but we know features associated with a bad prognosis or progression. I already mentioned deep ulcers. We know that patients who smoke have a bad prognosis. Patients who present with complications, perianal disease, we know that's a bad prognosis. They already have the complication. But the other is the need for steroids, and I kind of focus on that. Once a patient needs steroids, they probably should be considered having bad prognosis, progressive disease. And I took the position that in an ideal world, we should be inserting biologics before steroids.
And which patients really should be receiving biologics before steroids or at any point earlier in their management strategy?
Well, again, steroids are highly effective, but they're associated with the biggest number of side effects. We are all well aware of the systemic effects, but in the registries, we know that steroids are associated with an increased risk of infection, even compared to anti-TNF biologics, increased mortality. And so the majority of the complications in patients treated with anti-TNFs are really due to the concomitant medications, the steroids, and then as far as neoplasia is concerned, the the thiopurines, azathioprine and 6-MP.
And neoplasia, you mean lymphoproliferative disorders, non-melanoma skin cancers, what else?
Yes.
All those. Right.
All of the above.
And of course,
there are very few cancers that are associated with the anti-TNF biologics alone.
And I think that message is starting to get out, but not everyone has heard the updates, or at least what we're trying to communicate about that. So when you talk to a patient about going on an anti-TNF, and they say, I heard that causes cancer, what is your usual response to them?
My usual response is that's not correct. First of all, they're very safe, and even combination therapy, and we'll come to that in a second, is safe. In patients treated with anti-TNFs, the increased risk of lymphomas, lymphoproliferative diseases, are associated with the thiopurine therapy, not with the anti-TNFs alone.
Right. So you brought it up. Let's talk about combination therapy. So there was a lively discussion after the presentations about combo therapy. Both, is it needed for all biological therapies, including the anti-integrin therapies, specifically vedolizumab? And secondly, is it indefinite? So what is your current stand on that, and what should our listeners know?
So there are two potential benefits of the immunosuppressives with biologics. One is the potential of synergy, of having anti-inflammatory effects in addition to the anti-TNF effect. And the second is that the immunosuppressives are boosters. They improve drug levels of the biologics, and they reduce anti-drug antibodies. We don't know how to separate those effects right now. But for instance, in the SONIC trial that compared infliximab alone to azathioprine alone to the combination was both the most effective therapy, but within the first year also the safest. Infections and other complications were lower within the first year. The risk of thiopurines seem to be cumulative over years, and so that brings up your question of how long. We think that the effect on immunogenicity and the reduction in anti-drug antibodies is probably most profound over the first 6 to 12 months. So I think that's kind of the potential cutoff.
So if you're using combo therapy to minimize immunogenicity, then there may be a time limit to exposure where you're protecting them, and that, at least in theory, would make sense to consider withdrawal. But if you're using it for either boosting your biologic for a different reason or for a separate mechanism of disease control, then it may be indefinite, especially in higher risk patients, until we have something else.
Absolutely, and I think you've stated it correctly. But what I pointed out was the problem with current biologics, and we have more experience with the anti-TNFs, is that 50% of patients who start them are off within the first year. So we're doing something wrong. We're either using them too late or not using them most effectively, which led into some discussions of therapeutic drug monitoring.
Right, and we also discussed, and I think it's reasonable for people to be updated, that the dose of the concomitant therapy seems to matter more than we used to think, or at least we didn't know in the past. So the low dose azathioprine as the concomitant, or the 7.5 milligrams of methotrexate, seems like those were probably too low to have the impact that we had wanted. Are you using methotrexate?
Yes, we do, and it's been clarified, at least in rheumatoid arthritis, because there have been dose escalation studies with methotrexate, and 12.5 milligrams seems to be an optimal dose to reduce the immunogenicity with that. As far as azathioprine is concerned, we don't have as much data on that. Maria Abreo's group has looked and suggests that you may not need as high a concentration of thioguanine to reduce immunogenicity as you would to have a therapeutic effect, but I would think that those results are, very preliminary.
I agree, and they showed the cutoff was about 150 for 6TG, but again, we haven't seen that fully fleshed out yet. Let's talk about the anti-integrin therapy that was approved earlier this year in the US, vedolizumab, for both Crohn's and UC. Why don't you tell us a little bit about where you're positioning that and the discussion that we had today about that?
Well, vedolizumab has been tested in the same kind of populations that the anti-TNFs were, in patients who had not responded to conventional agents, and also in addition in patients who had not responded to anti-TNFs. Vedolizumab was more effective than placebo in both of those groups, in patients not responding to conventional agents and in patients not responding to anti-TNFs. But if you separate those groups, the benefits were less overall in the patients who had failed anti-TNFs. This goes into the same concept that I was discussing, in that the later you insert these therapies into treatment, the less effective they're going to be. And it's why I push for earlier therapy with all of the biologics.
Are you using vedolizumab before anti-TNF in any specific subsets of patients?
I certainly am. I'm using it before TNFs in patients who are more concerned about safety and in patients whose disease can be controlled given the need for some duration of the vedolizumab to take effect. So for instance, a steroid-dependent patient who's afraid of going on an anti-TNF for whatever reason, maybe they've been exposed to infections, maybe they have a family concern about lymphomas, those patients can be tided over until the vedolizumab has benefits.
We've done similar in our practice, and we've also looked at some people who have the post-organ transplant IBD, where they're already on immune suppression for the organ transplant, but get this somewhat paradoxical IBD. And also the older patients, same concept of the infectious concerns. And tell us a little more about the timing, just from your experience. How long does it take in terms of that bridging that you need for this drug to be where you need it?
Well, we know that the primary endpoint in the ulcerative colitis and Crohn's studies at 6 weeks was clearly too short. With the second Crohn's induction study, we saw a significant benefit at 10 weeks, but I don't think that's the ultimate. I don't give up for 14 weeks and probably may not give up for 6 months if I can control the disease without significant complications in the interim.
Sure. What about stopping therapies? So this was another hot topic, and I know it's of concern to our patients and our colleagues. When or can we de-escalate therapies, and in whom?
So combination therapy has been looked at both ways, stopping the immunosuppressive or stopping the biologic. And I think that the key concept either way is that you can stop either one if the patients are really in a deep remission. And I use the analogy of surgery. You know, we can do a surgical resection of patients and connect two healthy pieces of bowel in the setting of Crohn's disease, and the patients are going to, on average, do well for at least 3 years clinically, but we see subtle signs of the disease recurring. That's a deep remission. The patients can, quote, coast for that period of time. They're going to coast after biologic therapy is stopped, or they're going to coast after an immunosuppressive therapy is stopped for a period of time. And I think it's a patient selection. If cost doesn't matter, I think the biologic's probably going to be a bit safer long term. If cost is an issue, we can keep them on the immunosuppressive. And the best news is if they've been on therapy, combination therapy, for more than a year, we can go back to the original biologic if we need it.
So that's something newer. Certainly the dogma had been that once you're on a particular anti-TNF biologic, you should stay on it, and if you stopped it for any reason or missed doses or had a holiday, you probably couldn't go back. And now we've started to realize that that's not always the case. So can you elaborate on that? Who might those patients be? How do you restart? What do you do?
So it goes back to the beginning of our discussions about the development of antibodies and how combination therapy reduces it, and it's most significant at least over the first 6 to 12 months. After that, it's still dependent on maintaining blood levels, because as soon as blood levels of the biologics drop, patients are going to develop anti-drug antibodies eventually. So I think that's the concept, to give them control over the first 6 or 12 months, certainly, and then we can consider stopping.
And I want to make a distinction as well. If we talk about withdrawing a therapy, we're not talking about having patients on no therapy. Is that correct?
In general, I think that that is correct. We've both seen occasional patients who do very well for a while on no therapy, and rarely patients for a very long time. But the vast majority are going to recur. But I think the most important thing is if you're going to change or alter therapy or withdraw, is to still monitor the patient.
I agree.
Either with CRP, calprotectin, interval endoscopic examinations.
I think that's a really important message. So one of the areas that we've come to appreciate is how to monitor, because monitoring for subclinical recurrence gives you a window of opportunity to get them back on track. Now, you and I have done some work together recently looking at a deeper level of remission, where patients had achieved actually normalization of their biopsies in long-standing ulcerative colitis. Is that a new group of patients that we might even think about this differently, or are they still at the same risk? What do you think?
I think that they are at less risk, but probably still at risk. And our fellow Britt Christensen has submitted some very interesting data that, based on the level of deep remission and histologic remission or some persistence, that you can predict that the patients are going to eventually flare up. But we saw that actually a number of years ago from work from Great Britain. In the absence of neutrophils, the patients have a better prognosis. But you and Britt have shown that if you actually normalize the mucosa, including the architecture, and we never knew you could get rid of the architectural distortion, that's really what's new, that's a deeper form of remission. But the deeper you go, the better you're going to do.
I think that's probably right, but it doesn't get you away from monitoring. And so the fact that the patient's off therapy doesn't mean that they go away until they show up flaring. We want to try to keep them under our observation. And it certainly, at least based on what we know so far, doesn't mean that they're excused from the potential risk for cancer. And we don't want that to happen either, where just because they're on no medicine, they don't see us until they have a big problem.
Absolutely, and as you've shown with the studies looking at histology, even the histology predicts the risk of neoplasia.
So let's just shift gears a little bit. What about any updates or advances in the use of steroids or 5-ASAs? What are we learning at this meeting?
Well, I think you presented very interesting posters on budesonide. We've seen budesonide MMX was introduced for patients with mild to moderate ulcerative colitis as a first-line therapy. We kind of were concerned about the positioning at that point and thought more patients would probably use it on top of 5-ASA. And so your data, you can describe it better than I, suggests that it can be used on top of 5-ASA.
So in the original trials of the MMX budesonide, they excluded 5-ASA as a concomitant therapy. So this looked at more what people were actually doing, which was adding it to 5-ASA and 5-ASA patients who are not responding to those therapies. And although it was a small overall result, it was statistically better than placebo. The interesting finding from that study was that they achieved more histologic remission than even endoscopic remission, and nobody's really sure what that really means, other than the fact that the histology was read by a central reader. The endoscopy was read by the investigators participating in the study, and we know there's lots of variation in these things. But getting to the practical matter for people at home, where should they use budesonide then? And is this sufficient to keep them on it, or do they come off of it at some point? What are you doing?
We're watching it. So as you know, my belief is not making sudden moves. I transition patients. So I'm currently positioning budesonide MMX orally for patients who are on mesalamine who are not doing well. And I will add the budesonide MMX. Once they go into remission, I will gradually taper it over time. There are some patients who require it long-term, just as we've seen with the enteric release budesonide in ileal Crohn's disease. And as long as they're not having side effects, and the majority don't, but we monitor for bone density, cataracts over the long time, I'm willing to keep them on it because I think it's safer than going on the next level of therapy.
How do you taper it?
Since we only have the 9 milligram dose, I'm doing it every other day.
For how long?
Depends how long they've been on it. I kind of look at an equilateral triangle. The longer they've been on it, the longer I'll taper them off.
Have you had much experience with budesonide foam yet?
I have not. It's only been used in the clinical trials, but I look forward to it because we've used budesonide compounded as a suppository in patients with ulcerative proctitis and found it to be very effective, in particular in conjunction with the 5-ASA suppository.
So more effective than standard steroids? Because the question that's been raised is, will this be so effective that we won't use the less expensive standard steroid foam?
I don't know. Tell me, what do you know?
I don't know yet either. That wasn't a loaded question.
I haven't seen the actual data on that. We have not seen head-to-head trials. We do know that trials with prior formulations of budesonide rectally as enemas, that it was effective, but was not as effective as 5-ASA rectally. And as I mentioned, what I found to be very good is a combination of 5-ASA budesonide compounded. So I'm interested to get my hands on the foam, so to speak, and look and see how it performs in these patients.
So our last topic will be just about how you're monitoring your patients. Are you using fecal calprotectin? Do you use CRP? Do you scope? I'm guessing you're going to say yes. The question is, in whom might you use some of the other things than scoping?
I think CRP is increasingly going to be useful. The problem is that at the moment there's been a lot of selection bias in the publications, and the actual thresholds for calprotectin kind of go along with what we see endoscopically. Levels of 150 may correlate with endoscopic healing, but levels below 50 may actually correlate with histologic healing. So the further we want to push it, the lower the levels that we're going to actually accept as effective levels.
Are your patients willing to do fecal calprotectin? We
haven't done it en masse in large populations of patients. To this point, we've been using calprotectin like fecal leukocytes to differentiate inflammatory diarrhea from irritable bowel or other mechanisms. The problem with calprotectin, frankly, at this point has been it's pretty expensive. It's actually more expensive than doing a sigmoidoscopy in patients.
Well, when you factor in that insurance doesn't always pay for the Calpro.
Right, but the cost is the same as the cost of the doctor's fee for doing the procedure.
We've also used fecal calpro in our practice now in those patients in whom we dose de-escalate or withdraw therapy. So looking at a baseline is really important. You don't want to just get a value later and figure out what's going on, but rather using that in some serial way in follow-up. And without good data to guide us, I've just been doing it every 3 months or so for the first year to make sure we're in stable ground, and then I back off a little bit.
Well, as we discussed, Mark Osterman and the colleagues at Penn have published on looking at fecal calprotectin in patients treated with 5-ASA. And if they had an elevated calprotectin, what they did was increase the dose of the 5-ASA, and that actually reduced the likelihood of clinical flare-ups.
That's right. So there was a mucosal healing symposium this morning, and we talked about that. And actually, those were patients in remission. So the idea was in remission on 5-ASA, elevated fecal calpro, based on the idea that that likely represents subclinical inflammation. They were able to drive it down just by adjusting the dose of the 5-ASA.
And this gets back to the different levels of remission. There's a clinical remission, an endoscopic remission, histologic remission.
Now, on the monitoring topic, and the last question is really therapeutic drug monitoring with the biological agents. So other than the approach to the patient losing response to therapy, which is what we've talked a lot about, are you using the drug levels in patients who are stable?
I'm starting to do that now, but I have to admit that we don't have good prospective data regarding that. And as I mentioned in my discussion today, that's an important thing to develop. But we've had difficulty convincing our industry partners to do those studies. And part of the concern is that it may actually increase drug costs if we keep escalating dosing.
So this has been a great discussion. Congratulations again on a fabulous meeting, and I hope it continues to grow. This has been a great discussion, Best of the Day from Advances in IBD in Orlando, Florida 2014. Thank you for joining us.